So in the same way that COVID-19 is impacting many industries, it's also impacting healthcare delivery, and in a number of ways. The first is that in some institutions, the availability of staff is reduced. We are being very vigilant about any staff member who may have any symptoms, may have had any contact with a person with a proven COVID-19 infection. They're being very vigorously quarantined, tested and screened. And so even though staff may be well within themselves, if there is any risk of them potentially having COVID-19 or any other virus infections as we're coming into the cold and flu season, generally most institutions are ensuring that they do not attend work, do not expose their co-workers, and do not expose patients to potential risks. Now, what that can mean is that staff numbers may be reduced. And so all institutions are needing to carefully assess what staffing levels do we have, what services can we deliver. The second issue is, as we talked a little bit earlier, about minimising contact with other people and minimising leaving the home except for essential activities. One of the things that our institution, and I'm sure every institution is doing, is looking very carefully at how can we maintain the quality and care for all of our patients, but is there a way we can do that with less need for contact? And some of that is, can we use telehealth review instead of bringing people in to the institution? Are there ways that we can deliver care coming to a person's home or reducing the duration that they need to be in the institution? And some of those things are using chemotherapy in the home instead of coming into the hospital, or using shorter infusion times or subcutaneous delivery of an injection under the skin rather than a prolonged intravenous drip into the vein, where those treatments do not compromise the effectiveness. And again, that will vary depending upon the actual treatment and where you are in your disease. But generally, all institutions are asking themselves critically, how can we deliver effective treatment with the minimal contact, the minimal exposure to patients, and how can we do that in the most effective way if our staff numbers are reduced. The second element that we then need to consider is, in our current environment where there are risks of patients contracting COVID infection, and we know that reduction in the strength of the immune system increases the risk of those complications, we're re-evaluating the risks and benefits of particular treatments in particular disease settings, and where it is possible to do so without compromising the health, the well-being, and the overall outlook of patients, those treatments that are associated with an increased risk of infection, we're asking the question, can that safely be delayed for a number of months? And that really applies to the more indolent diseases. Some of the slower growing lymphomas, some of the forms of chronic leukemia, particularly CLL, and in some cases, multiple myeloma, where the disease is more gradually progressing. Now, the balance here, of course, is there can at times be risk from the disease, allowing it to progress without treatment, and the disease itself can also compromise the immune system. So that can be a very nuanced and balanced discussion that each individual patient needs to have with their treating doctor to come up with the right balance for what is the right time to initiate treatment for you, and your disease in these current circumstances. And that will change depending on what the perceived risk in the community of contracting COVID-19 is. At the moment, community transmission in most areas of Australia is still very low. And so those decisions about risks and benefits will need to be evaluated depending upon how prevalent, how widespread COVID infection is within our communities.